She told me don't worry about it. She told me don't worry no more. We both know we can't go without it. She told me you'll never be alone. I can feel my face when I'm with you. But I love it. But I love it. Oh, I can feel my face when I'm with you. But I love it. But I love it. And I know she'll be the death of me. At least we'll both be numb. And you'll always get the best of me. The worst is yet to come. All the misery was necessary when we're deep in love. This I know. This I know. She told me don't worry about it. She told me don't worry no more. We both know we can't go without it. She told me you'll never be alone. I can feel my face when I'm with you. But I love it. But I love it. But I love it. I can feel my face when I'm with you. But I love it. But I love it. But I love it. But I love it. I can feel my face when I'm with you. But I love it. But I love it. But I love it. I can feel my face when I'm with you. But I love it. But I love it. Oh.
Okay, in this video, I'm going to cover maxillary and mandibular local anesthesia. So we're going to talk about the different nerves that get anesthetized and the location of those injections. So unfortunately, you guys cannot administer local anesthesia, but you are required on your national board exam to understand the location of those nerve blocks and injection sites and the pharmacology that goes along with it. So essentially you have to understand the didactic component of local anesthesia, but you have a disadvantage because you cannot practice that when we go into the clinic. So let's get started. Maxillary injections that we're going to talk about will be the posterior superior alveolar, the middle superior alveolar, the anterior superior alveolar, the infraorbital, greater palatine, nasopalatine, and the anterior middle superior alveolar. So some of those are really a mouthful. When you guys are doing your second practical exam, you will not be able to use these abbreviations. You need to know what the full name is. But when we are in the clinic, we will typically refer to them as PSA, MSA, ASA. So we'll refer to them by their abbreviations. So I'm going to let you guys finish filling that in for just a second here. And if you need to, again, you can pause that video at any time. Okay, so on these maxillary injections, maxillary blocks, what you need to understand is that most local anesthesia on the maxillary is more successful than that on the mandibular because the bone, that cortical bone over that facial surface of the maxillary teeth is less dense than that of the mandible over similar teeth. Very thin amount of bone, so that anesthetic is able to permeate that bone a little bit easier. The injection with the highest fail rate, we're going to talk about that later, but that's the inferior alveolar, has the highest fail rate. But typically those maxillary blocks, they are very effective and very quickly effective. So if I were to ask you on an exam which arch had the most success rate with local anesthesia, that would be the maxillary. Okay, let's talk about the posterior superior alveolar. The posterior superior alveolar, or PSA block, is used to achieve pulpal anesthesia in the maxillary third, maxillary second, and the first molars in most patients. I would say it's part of the first molar. So the PSA block anesthetizes the buccal periodontium overlying the maxillary third, second, and first molars, including the associated gingiva, periodontal ligament, and alveolar bone. That's a lot of words. So let's look at this picture. So luckily, the nerve blocks are named after the nerves themselves. So here we have the maxillary nerve, V2, off of the trigeminal nerve. Remember, I told you in the other video you needed to know the three branches of the trigeminal nerve. So that maxillary nerve comes off of the trigeminal nerve, and then we have these other nerves that come off of the maxillary nerve, and one of those is the posterior superior alveolar nerve. Now let's look at how this nerve comes down. You can see that it covers most of first and second molars, and then some of this third and second molars and some of this first molar. So here's that nerve right here. So when we're anesthetizing the PSA, we are putting anesthetic right back here in this area to try to catch this part and this branch right here, to catch all of that. So what does the PSA anesthetize? You guys should have this in a big picture that you've printed off. But let's look at PSA. Now, this picture is only going to show us, one side, but it would be the same on the other side. So here we have the PSA on the right side, and it has anesthetized the entire tooth and pulpal tissue of the third molar, the entire tooth and pulpal tissue of the second molar, most of that first molar. So it's going to anesthetize all of the first molar except for the mesial buccal cusp. Now, what I want you to remember about these maxillary injections, this is very important. Look at the yellow on that tissue. Those injections this PSA is going to anesthetize the buccal tissue, but not the lingual tissue. Now, part of our problem as a hygienist, when we're doing periodontal therapy, when we're doing SRP, we need good anesthesia, particularly with those more difficult cases. I hear a lot of people say, well, we only use topical or Orikix in our office. We don't ever anesthetize for SRP. Well, either they're seeing very easy SRP patients, or I'm concerned about their ability to be thorough, because that is a painful procedure. And so if I'm working on this entire upper right quadrant, we're going to have to give a lot of injections in order to get that patient comfortable. So SRP requires more injections for that procedure than most dental procedures. So we need that anesthetic a lot more. Excuse me. The injection site for the PSA is in the tissue at the height of the mucobuccal fold. So right where the gum folds by the alveolar bone there, at the apex of this maxillary second molar, distal to the zygomatic process of the maxilla. So we're going to go to the right in that fold at the apex of the maxillary second molar. So we're going to go right there, and then we're going to be distal to the zygomatic process. Okay, let's move on to the middle superior alveolar, the MSA. So this is going to be for dental procedures on the maxillary premolars and the mesiobuccal root of the maxillary first molar. So if I'm working on that first molar, if I'm a dentist and I'm doing a crown on that first molar, I'm going to probably give a PSA and an MSA, unless I'm doing infiltration, which I'll talk to you about that in just a minute. But since, remember on that PSA, let's go back to our picture here, that mesiobuccal root of that first molar is not covered by the PSA. So I'm going to have to give the MSA as well. MSA block anesthetizes the pulp of the maxillary first and second premolars, and possibly the mesiobuccal root of the maxillary first molar and the associated buccal periodontal tissue, including the gingiva, periodontal ligament, and alveolar bone, if the MSA nerve is present. Some people don't have that MSA branch coming off. Let's look at a picture here. So here we have the middle superior alveolar nerve. Supposedly, some people don't have this nerve, or it is shortened, and so the PSA and ASA are take over for the lack of that MSA. So our MSA is going to anesthetize both premolars and their pulpal tissue, buccal periodontium, so the buccal gingiva, not the lingual. So again, if I'm doing scaling and root planing and I manipulated that gingival tissue, the PSA and MSA are great for the buccal, not so great for the lingual. Middle superior alveolar injection site is going to be, again, at the height of the mucobuccal fold, right where that gingiva folds in that little crevice there near the alveolar bone, at the apex of the maxillary second premolar. So here we have our maxillary second premolar. We're going to go all the way to the apex here, and that is our injection site for the MSA. When you're doing SRP in the clinic and you have a patient that needs local anesthesia, you're going to have to be able to tell your instructor which nerve blocks you need anesthetized for your patient, and you're going to have to apply the topical anesthetic to this injection site. And so in order to make it more comfortable for our patient, we put a little bit of topical anesthetic, we rub that on the tissue, and then that's going to anesthetize the tissue so that they don't feel that needle going in. Some people think that that is purely a psychogenic effect, that it really doesn't do anything, but personally, I want the anesthetic rubbed on my tissue. So whether it's just in my mind or not, I'm going to want that. What I see a lot of times in people who don't understand the injection sites for anesthetic, they'll just take that anesthetic and rub it all over the tissue because they don't really understand where that anesthetic is being injected. When we know, we can limit the amount of topical anesthetic that we place on that tissue, and dry it off really good, and hopefully have a little bit of a better effect. Okay, our anterior superior alveolar, or ASA block. So this one is commonly used with the MSA instead of doing the infraorbital block, and I'll talk to you about why in a minute. The ASA block anesthetizes the pulpal tissue of the maxillary canine and incisors, as well as the associated facial periodontal tissue, including the gingiva, PDL, and alveolar bone. So let's look again at our picture here. And again, this one is appearing several times, so I would really study this one. Here we have the anterior superior alveolar nerve. So all three of these nerves, the PSA, MSA, ASA, all come off of the maxillary nerve, which is a branch of the trigeminal nerve. The ASA area of that gets anesthetized: canine, lateral, central, and buccal tissues. Again, not the lingual tissues. This is a problem for us as hygienists. The injection site for the ASA is at the height of the mucobuccal fold, at the apex of the maxillary canine, just anterior and parallel to the canine eminence. So we're seeing some of these things that we've learned come back. Those are going to serve as landmarks for us for other things. So if you're not familiar with what the canine eminence is, then you're going to want to go back and review that. Okay, the infraorbital block, or IO, is if you're doing a lot of, for instance, if you were going to do a lot of anterior crown work, this would be great because it's going to anesthetize the middle and superior alveolar nerves at one time. So instead of giving 2 different injections, you can give 1 and get them both. The problem with the IO is that it will also anesthetize half of your nose and sometimes all the way up to your eye. So it's a little weird for the patient. The IO block is used for anesthesia of the maxillary premolars, canine, and incisors. So the infraorbital nerve comes out of the infraorbital foramen. And this is basically the tail end of that maxillary nerve. So you can see how it branches up, out, and down. So when we anesthetize the infraorbital nerve, that anesthesia is going to travel up and anesthetize usually to the middle superior alveolar nerve. So here you see the large area that the infraorbital nerve will anesthetize. So here is the tissue that gets anesthetized posteriorly, and it is a very odd feeling for your eye to be numb, to have that weird dry sensation in your eye. So injection site for the IO is at the height of the mucobuccal fold at the apex of the maxillary first premolar. So that MSA, we anesthetize at the apex of the second premolar. The ASA, we anesthetize at the apex of the canine. The infraorbital is at the apex of the maxillary first premolar. Okay, so we talked about how all of those, the MSA, ASA, PSA, they anesthetize the teeth and the buccal tissue and not the lingual. So if your dentist is going to do an extraction on number 2, they're going to need that lingual tissue to be anesthetized as well. If you are doing a really difficult SRP, you're going to want that lingual tissue anesthetized too. The problem with anesthetizing that lingual tissue is that the gingiva on that palate is not as pliable. Tissue is very, very tight back there, which means that putting pressure with a needle in that area is going to hurt. So it's much more painful to give those lingual injections. This is not a great view of the greater and, well, we have the greater and lesser palatine nerves because they're actually on the lingual side, so all you can see is where they're branching off there. So here we can see where the greater palatine, this is where the greater palatal foramen is, and that's where that nerve can be accessed. And so we can anesthetize a pretty large area with that greater palatine block. And it's going to anesthetize all that lingual tissue if you need it. Palpation of the depression created by the greater palatine foramen. Surrounding palatal tissue is blanched throughout the injection. Can you guys see how they are pushing on that tissue with this cotton tip applicator? That is what we call a distraction technique. Some people will use the end of the handle of the mirror to do the same thing, and when you push on that, as you're entering with that needle, the patient is distracted and they can't quite tell whether the pain or sensation they're feeling is from the pressure of you pushing or from the actual needle. Unfortunately, even with topical anesthetic, they're going to feel these lingual injections. That tissue is so tight back there. The nasopalatine block is going to anesthetize the tissue on the lingual where that ASA could not anesthetize. So that, here we go, that the incisive foramen is where the nasopalatine nerve is. And that's right where you're injecting. So here we have the incisive foramen, and this is the tissue that is anesthetized by the nasopalatine. The injection site is going to be the tissue right to the side of the incisive papilla. If I were to ask you on a test which injection site is the most likely to cause pain, it would be this one. This is the most painful injection that we can give. So we try to avoid giving that nasopalatine unless we absolutely have to. That tissue on the back side is so incredibly tight, it just hurts. We don't like to have to give this one. The anterior middle superior alveolar is going to give us additional pulpal and gingival anesthesia in the area that was also covered by the ASA, MSA, greater palatine, and nasopalatine. Our injection site for the AMSA block is going to be bisecting the apex of the maxillary premolars. So essentially between the two apices, between the lingual gingival margin and the median palatine suture. Orientation of the syringe should be contralateral to the premolars. That just means that the handle should be to the other side. Okay, let's go ahead and go to our mandibular blocks. You should have a printout for your mandibular blocks as well. Our mandibular blocks that we're going to talk about are the inferior alveolar, the buccal block, the mental block, the incisive block, and the Gaugates mandibular block. First, we're going to talk about the inferior alveolar block. You guys remember me saying earlier that this one has the highest fail rate. That is because this one is the most technique sensitive. What do I mean by that? I mean that it is the most difficult to get to. So we have to use our landmarks and feel, and this one also has a high variability of anatomy. So it is the most likely to not conform to what we know traditional anatomy is. A lot of people have a problem with hygienists administering this particular block because it is the most difficult to get down. So some states will allow hygienists to administer local anesthesia but not give blocks. So they want hygienists to only be able to infiltrate. So what do I mean by that? Infiltrate versus a block. Let me go back to this picture. A block is when we take that needle and we go up and get a larger branch of a nerve so that it then anesthetizes multiple teeth. So we're getting a bigger branch of nerve. Infiltration is where you take that needle and you're placing it just right here at that tooth. And so I'm only going to be able to anesthetize this one tooth and maybe part of the tooth beside it. So what happens is you have to end up giving a lot of injections. If you're going to infiltrate, you're going to infiltrate here and here and here and here and here and here. Lots of injections. But much, much easier. And literally you can't go wrong. If you just place the tip of that needle 2 millimeters under the gingiva, you're going to anesthetize the tooth. Very easy to infiltrate. So infiltration is anesthetizing the small nerve endings right above the tooth. And a nerve block is actually blocking a branch of a nerve that anesthetizes multiple teeth. So a block is going to be much more technique sensitive. Okay, let's go back to inferior alveolar nerve. This one, the good thing about the inferior alveolar nerve is that once we anesthetize that nerve, it's going to numb most of the quadrant, lower right or lower left quadrant that we're working on. Let's look at this picture. Here is the inferior alveolar nerve. And it's going to go all the way down and anesthetize all of these teeth. So if I can anesthetize here, I don't have to give all these other little injections. So remember on the maxillary we had multiple branches of a nerve, so we had to anesthetize several nerves up here. Down here we just have this big nerve here. There's some limitations though, which we're going to talk about. Inferior alveolar nerve, here we have the IA in green. So what we see is that it has anesthetized the teeth and pulp, all of the gingiva in the lower anterior, but what we're missing is the buccal gingiva by these molars. So as a hygienist, if I am doing SRP and I go in and I start here and I get all the way down to here, and then my patient starts to jump right when I get around this premolar, it's probably because the IA did not work. So I had buccal anesthesia here because we do a buccal block as well. So the buccal block here, and I thought, oh, I've got good anesthesia, I'm working, and then I get here and the patient starts jumping. Then I should know my anatomy and my nerves and know, oh, hold on, let me stop and go get the dentist to come back because we need more anesthesia on that inferior alveolar nerve. So that's going to be our limitation, is that it does not anesthetize the buccal tissue of those lower molars. We have to do an additional nerve block on that buccal nerve in order to get that tissue. Okay, here we're going to watch an example of the inferior alveolar injection. Take some of the mystery out of it. And try to see if you can recognize some of the anatomy as they're doing this. If you need to, you can back that video up and watch it again, because there are some landmarks and you can slow it down if you want to really identify what you're looking at. So our injection site for the IA block is in the mandibular tissue on the medial border of the mandibular ramus at the correct height and anterior posterior direction for the injection. Okay, the buccal block or long buccal block, a lot of people do call it the long buccal block, is useful for anesthesia in the buccal periodontium of the mandibular molars. So here, this is a lingual view. We have the mandibular nerve, V3, which is the third branch of the trigeminal nerve. And then that's going to branch off into different nerves. So here we have the buccal nerve, and it comes right around here. So when we're giving that inferior alveolar, we inadvertently also hit that lingual nerve, so it does anesthetize the lingual nerve, but it's not going to get this buccal. So we have to come out just a little bit further and give a buccal block. So again, the buccal block is going to anesthetize the tissue on the buccal of the lower molars. The injection site for a buccal block is the buccal tissue distal and buccal to the most distal mandibular molar tooth in the mandibular arch on the anterior border of the ramus. So it's a little bit more anterior and inferior than the inferior alveolar. We're going to go through these last couple very quickly. The mental block is going to anesthetize the facial periodontium of the mandibular premolars and anterior teeth on one side. We don't typically do a mental block unless we're having a hard time with the inferior alveolar. Then sometimes they'll come back and do a mental block. So the mental nerve comes out of the mental foramen. Injection site, we're not going to worry a whole lot with these. Like I said, we're going to move through them quickly. The incisive block anesthetizes the pulpal and facial tissue of the mandibular anterior teeth, anterior to the mental foramen. So up here. And I think that's all in our in our PowerPoint, there is Gal Gates. We're not going to go much into the Gal Gates. I have personally never seen anybody do the Gal Gates. I want you to know that it is an actual injection in case you ever hear of it again or see someone do it. I have heard of hygienists doing the Gal Gates. I see people talk about it in the forums. I've just personally never seen anybody do it. So we're really not going to focus on it. So if you had a patient that you needed to do SRP on the upper right, what I would like to hear you say is that you need anesthesia in the PSA, MSA, ASA, and possibly the greater palatine, or infiltration. And if you needed it in the mandibular, I would want to hear you say that you needed an IA and a buccal or a long buccal block. You do not need to know that for your test. You have not even studied periodontal disease and SRP yet. But I want you to be familiar with it and at least hear it so that when it comes up again, it won't be completely foreign to you. Okay, that's all for our lecture this week. So if you guys have any questions, please feel free to email me, and I will get back to you as soon as I can.